What is it like to go behind the scenes of CRNA School Simulation Lab? That's what we're talking about today. My name is David Warren and I am a CRNA student. I'm also a nurse practitioner, and that's what my content is all about. If you are interested in that, consider subscribing for more related content. Today, we're talking about what Simulation Lab has been like overall. To give you a little background, I am at National University in Fresno, California. I'm in a front-loaded CRNA program. I started in January of 2022, and as of yesterday, I just took my last final exam and I am done. I passed the didactic phase. I'm headed to clinical in about a week and a half, and I can't wait to share that journey with you. But today, I kind of want to talk to you about what Simulation Lab has been like. I have filmed other videos on what the in-class portion has been like, and I've touched on the Simulation Lab a little bit, but today I want to do a dedicated video and show you and tell you about what Simulation Lab has been like if you are a CRNA student or if you're considering going to CRNA school. You're probably in a similar circumstance as far as Simulation Lab. And so I kind of want to break that down for you and give you a little insight on what you can expect going forward if you're either in this program or if you're considering other CRNA programs. So the first 15 months of the program, in the program that I'm in, we learned all of the didactic component of being a CRNA. And so that's all the textbook learning, and then we had these intermittent simulation labs as well. So really starting in Q2, our year is broken up into 4 quarters. So last year, starting in Q2, is when we did our first simulation lab. And then we had a lab in Q2, 3, and 4. And then I'm currently in Q5, which is our last didactic quarter. And we had our final simulation lab. So this quarter, the simulation lab was all about crisis management and intraoperative emergencies. And I have my syllabus pulled up here on my iPad, so I'm going to intermittently be looking down. But I want to take you through kind of what we've learned this quarter, what our exams have been like, and what the pearls that we have learned from our clinical instructor have been. And so our simulation lab meets once per week. So starting last year in Q2, 3, and 4, we would meet in a separate AM and PM group. So there's about 22 or 23 people in my entire cohort. And if you could imagine in simulation lab having like 20-something people in there, that's not like super conducive to learning. So in our simulation lab, it's a pretty good sized lab. We have 2 anesthesia machines, a few ultrasound machines. We actually had to purchase our own ultrasound, Butterfly IQ ultrasound machines before we started the program. We've been using those intermittently as well. And then we have, again, 2 anesthesia machines and 2 high-fidelity mannequins that we can practice with in the simulation lab. We also have everything that you would probably need behind the drape in the anesthesia field. So laryngoscopes, video laryngoscopes, fiber optic bronchoscopes, really anything that you would think of that you might need. We have an Airway cart, we have a medication cart with all the meds stocked, ET tubes, really anything, like I said, that you would think of that you might need in the OR as anesthesia. We have that available to us in the simulation lab. And over the past year, we have learned how to use those different pieces of equipment. And this quarter kind of tied all of that together. So in our previous simulation courses, we would have different cases that we would go through, and our exams would be like a checkoff rubric for a patient case, and we would go down that rubric. And this quarter was a little bit different, and I kind of want to get into the details of that and show you what that has been like. So our simulation course would meet in an AM and a PM group, as I said earlier, 20-something people, not super conducive to learning. We split the class into 10 to 12 different people, an AM group and a PM group, and we would meet in our dedicated class like 4 to 5 hours a day. So the AM group would meet like 8 to 12, and then the PM group would meet like 1 to 5, and so right at 4 hours. And we would stay a little after, to practice as well before the next group would come. And so we had a dedicated meeting once per week. And then we would also do what's called small group signups. And so the small group is where we would sign up on a Google Doc with our clinical instructor for like a 1-hour segment, and there would be 4 people per 1 hour. And we did this maybe 2 or 3 times throughout the whole quarter. And it was super helpful because it allowed us to actually get detailed one-on-one instruction with our clinical instructor or our simulation instructor. And it's different than having like 10 or 12 people. Like you still get some instruction, one-on-one instruction, but it's much more conducive when you get that like 1 hour of dedicated instruction. There's only 4 people. So we did that a few times, usually before an exam, to kind of help us prep and help us get ready for whatever that exam might be. And then in the regular non-small group classes, which again were the majority of the classes that we attended, We would have a lecture that usually lasted 30 minutes to an hour to kind of introduce the concept that we were learning that day. And then we would all go to the simulation lab, and our instructor would run through different scenarios with us, or how to treat different scenarios based on whatever we were doing that particular day. And so our quarters are 12 weeks long, and so I've got my syllabus pulled up here. I kind of want to take you through what that's been like and what we learned this quarter. So our first week, we did crisis management, hypoxia, laryngospasm, and bronchospasm. And so we had an initial lecture on how to deal with all those different types of emergencies. And I'm not going to go into like each specific one because the video would literally be a few hours if I had time to explain all of the things that we went over. But just as a general overview concept, we went over things like hypoxia, laryngospasm, bronchospasm that first week, had a small lecture, then would go to the lab and our instructor would show us on the high fidelity mannequin, how do you manage those things? So if you're in the OR, your patient's under general anesthesia, or if you're getting ready to induce the patient, or you've just extubated the patient and they have one of those things happen, how do you manage it? What does that look like? What are the steps to doing that? And so that's what we did our first week. The second week was, again, the small group sign up. So we would sign up for that hour-long segment, 4 of us at a time, and then our instructor would be like, okay, David, your turn, go to the head of the bed. This is your patient. This is the weight of the patient. What are your induction drugs? What's your plan? And then during that phase, she would give us a scenario. We have vital sign machines there that she would operate with her phone to give us a representation of what the patient's vitals were, and then we would address the emergency or the situation based on whatever it was that she had for us. And so that was super helpful. So the third week, we did difficult airway and failed airway management. And so again, we had a bit of a lecture on what is a difficult airway, how do you approach the difficult airway, what are the different techniques that you can use to manage the suspected or known difficult airway. And I will say the difficult airway has come up quite a bit because we have touched on difficult airway in some form or fashion in every class that we've had. And so that's kind of been a theme through my didactic phase of CRNA school is there have been a lot of things that we have touched on multiple times that keep coming up over and over again. And it makes sense because you really need to hit on those things multiple times, especially difficult airway, because that's something that you could deal with potentially every day of your career. You could deal with a difficult airway. And so having those things that come up multiple times over, refreshing yourself every time you hear it has been helpful for me. And so that was our third class. The fourth class was surgical airway practice on pig tracheas. So that was actually a really fun class. We had pig tracheas, and we practiced doing cricothyrotomies on these pig tracheas, how to do a cric. And it was super interesting because in my former emergency medicine career, I know how to do a cric. I've never done one personally on a live human, but I've been trained in it in school, in my NP training, and then in some ancillary emergency medicine courses that I've had to take over my career. So it was cool to learn the anesthesia way of doing a cric, which again, a cric is a cric. A CRNA may do the cric the same way as an emergency medicine provider. It's all a flavor of the same type. However, there are different techniques. You can use the scalpel, a bougie and ET tube over. They make cric kits that have the guide wire. You can do a Sellinger technique. There are a variety of different ways to do that. And so we went through some of those scenarios. And then in week 5, we did small groups again, and that was, again, meeting 1 hour at a time to go over different scenarios. And then in week 6 was our first exam. So our exams, we had 2 exams in this course. We had a midterm and a final. And our midterm was around week 6 or 7, and our final was around week 11 or 12. And so we had 2 different days to do finals on. So week 6 and 7 were the 2 final exam times that we were able to go. And so the AM group would go all day on week 6, and then the PM group would go all day on week 7. And it may have been backwards, actually. The PM group may have gone first in the AM group, and then for the final it switched. The PM group would go first in the AM group, whatever was opposite of the initial midterm exam. And so really you had kind of a week off in lab. I really had 2 weeks off in lab for those 2 things. So 1 week, as I said, week 6 and 7 would be the AM group and the PM group testing. So whatever group that you weren't in, so if the PM group tested on week 6 and I was in the AM group, then I basically had week 6 off, and you had a week off from lab. Again, you still had you had to get ready for your exam and stuff, but you didn't have to show up to lab. And so that was kind of nice. We really had 2 weeks throughout the whole quarter. So our quarter was 12 weeks. Really 10 weeks were dedicated to being on campus, required to be on campus for the lab. And then, so our first exam was over a scenario, and each like class that we had during that initial lecture phase of the like day when we were in simulation lab, our instructor would give us different patients. And so she would give us like 3 or 4 patients per day and be like, hey, this is a 19-year-old female, give their weight, the medical history, their surgical history. And then we would kind of talk through what a plan would be. Like, what would your induction drugs be? What's your maintenance plan for this patient? What's your airway plan? What's your wake-up plan? Things like that. And so that was super helpful because on our midterm and our final, we would be randomly given a patient. And so by the midterm, I think we had 8 patients, 6 or 8 patients, and we would just randomly be assigned a patient. And then our scenario would be for that midterm exam, either hypoxia, laryngospasm, or bronchospasm, or difficult airway. So we would be given a patient, and they were all different. So your inductions are going to be different, your maintenance phase might be different, your awake versus deep extubation would be different for each patient, your airway plan would be different based on whatever was going on, if they were in anticipated difficult airway. So that's kind of how we did our exams in that course, that midterm exam. We would each have a different patient. And that was different from the prior exams in prior quarters, because in the prior quarters, we all had like a standardized patient that we would go through. But this course, it was quite different because we would have like each different patients, and it was really up to us to kind of, there wasn't like a set rubric to be like, okay, you have to do this, 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 and this for this patient. It's like, what do you think is appropriate for this patient? What's an appropriate amount of fentanyl to give? What's an appropriate amount of propofol to give? A neuromuscular blocker? Like, it was kind of up to us to critique and to craft our own anesthesia plan, which is really what the real world is like, because there's no like right way to do, or no one way to do, there's a right way to do anesthesia. There's not one way to do anesthesia. You can do multiple ways. For instance, if you have a normal healthy patient, you can use propofol for induction. You can use etomidate for induction. You can use ketamine. There are a variety of different combinations, and it's not necessarily right or wrong. Like, there are some indications, obviously, of when you might want to use etomidate over propofol, and there are some indications of when you might want to use ketamine over propofol or etomidate. So depending on like the patient, there are multiple ways to do that anesthetic. And so that's kind of what was introduced to us this quarter, is like, you can choose your own plan as long as it's appropriate for that patient. And then in the middle of that scenario, we would either have hypoxia, laryngospasm, or bronchospasm, or difficult airway, and we would have to deal with that and appropriately deal with those scenarios. And so that first week was kind of the introduction to what our midterm exam would be like, and then those small groups, we had a chance to walk through those scenarios with our clinical instructor. And so that's what the first exam was like. So fast forwarding to week 8, so week 6 and 7 were our 2 exams, AM and PM group, and then week 8, we did hypotension and anaphylaxis. So how do you manage intraoperative hypotension? What are the differentials for intraoperative hypotension? And then how do you manage anaphylaxis? And then our week 9 was, again, a small group sign up, so doing that 1-hour segment with our clinical instructor. We would go in and practice these scenarios. And our final exam, in fact, there's just still a couple of weeks in there that I'll get to, but fast forwarding to our final exam was going to be, and again, each week we accumulated like a couple new patients in that lecture phase of the simulation lab setting. She would give us a few new patients, be like, okay, these are the patients' weights, medical history, surgical histories. What's your plan? And we would all talk through it in that simulation lab setting. Like, what would you give for induction, maintenance, emergence, extubation, etc. And then so by the time the final exam rolled around, we had a bank of like 12 different patients, and we would just be randomly assigned a patient. We would go into our lab or our exam, and our name would be beside a patient, like your name would be on the runner board in the OR, and that's the patient you would be taking care of for that particular exam. And on the final exam, so I mentioned earlier on the midterm exam, we had hypoxia, laryngospasm, bronchospasm, difficult airway. And then on the final exam, it was either hypotension or anaphylaxis. And so for the final exam, we could have one of 7 of those different scenarios. So anything from the midterm all the way down to the final. And so you didn't know what you were going to get until you got in the scenario and had to like troubleshoot what was going on and fix the problem. And so that was the like crisis management that we had. Okay, so going back to the small group, week 9, we would practice doing those different scenarios. She'd be like, okay, David, go to the front of the bed, or go to the head of the bed. This is your patient, and do your induction, whatever. And then she would throw some kind of emergency at us, anaphylaxis, hypotension, whatever. How do you treat it? How do you go down that pathway? And so that's what the small groups consisted of. And I mentioned that earlier, that it was time for like hands-on instruction, one-on-one instruction with the instructor. And I found that to be super helpful. Like this was the first, really last quarter was the first quarter that our instructor incorporated those small group signups. And I wish it had been incorporated from the start, because it was super helpful to have that like one-on-one instruction. Okay, week 10 was a Q&A session with some CRNAs from the local community here. And so, as I said, this was our last simulation course. We're getting ready to go to clinical in like a week and a half. And so we did a like face-to-face clinical orientation. And so our clinical instructor brought in like four or five different CRNAs from the community. And we had a chance to just have a question and answer session, the whole class at one time, question and answer session with the CRNAs, like what are your expectations? And these are potential places that we may go as students to those clinical sites, but like I'm going to Henderson, Nevada, so I'm not even going to be in the area. So again, like I'm not going to be working with these people, but it's good to know like what are your expectations for a first or second year SRNA, like first clinical experience? What are your expectations, X, Y, and Z? So we just had that question and answer session back and forth. And so again, that was not really like a class. It was a class in the fact that we had to show up, but we weren't like tested on anything. It was just more like a question and answer session to prep for clinical. And then week 11 and 12 were our final exams. So week 11, again, like the PM group would go, week 12, the AM group would go. And it was just like I said earlier. So we would be assigned a patient, and then we would have a scenario from whatever we'd learned that quarter. So again, hypoxia, laryngospasm, bronchospasm, difficult airway, hypotension, and anaphylaxis. So in my final exam, I just took that yesterday, and it was very interesting. Like I didn't know what to expect, but the patient that I got was a like 56-year-old female, laparoscopic assisted vaginal hysterectomy. She had prior facial burns and neck burns, had skin grafts, could only open her mouth like 4 centimeters. And she was the only patient in the whole like bank of patients that we had discussed doing an awake fiber optic intubation. And that like changes everything. So my patient had to do an awake fiber optic intubation yesterday, and I've practiced it a little bit, but like during the simulation, it kind of throws you off, because like a normal induction, you're giving like fentanyl propofol and neuromuscular blocker, and then you're doing direct or video laryngoscopy, pre-oxygenating before, checking breath sounds, etc. And it just like the whole awake fiber optic thing like threw me off a little bit. I passed. I made a 98 actually, but yeah, it threw me off just a little bit doing the awake fiber optic, because you have to sedate the patient. You want to keep them breathing, so you can't use like slugs of propofol. So you can't give like 200 milligrams of propofol. You know, we use Presidex and ketamine and Versed to keep the patient awake and breathing, but sedated. You have to numb the different nerves of the mouth and throat to be able to pass that fiber optic scope down. Then you have to like spray the cords with lidocaine to get them numb, and then slide the tube over, and then secure the tube, and then you give propofol, rock, etc. to get the patient out. So that's what my scenario was. And then during the scenario, I had it was a laparoscopic surgery, so during initial insufflation of the abdomen, which is when they put the Varus needle in or the trocar in to insufflate the abdomen with CO2, you usually have an SNS response, so sympathetic nervous system, hypertension, tachycardia, etc. However, you can have a reflex bradycardic hypotensive response, and that's a little more dangerous, obviously, than hypertension. And so the heart rate dropped to like 27 and the pressure was like 60/30. And so you have to tell the surgeon, stop insufflation. And then you give atropine glyco or atropine glyco if it's like minor bradycardia. But again, the heart rate was like 20 something. So you automatically give 0.5 or 1 of atropine, get everything stable, desufflate, and then they can re-insufflate when the vital signs stabilize. So that was the first scenario that I had. And then there was some hypotension that we had to deal with. And so really this quarter, again, was about managing those emergencies. And really the big point that was hammered home was don't do the same thing over and over. So if you give phenylephrine, which is a direct alpha agonist, you want to not give that like multiple times in a row. Like give 200 mics of phenylephrine. Don't repeat the dose if it doesn't work. Like clearly it didn't work the first time. Don't repeat it. Give your phenylephrine, then give your ephedrine, and then escalate to vasopressin, and then escalate to epi or norepi. So you're kind of like escalating up the line. And so that's what we did in this hypotensive scenario. Like the patient's blood pressure just wouldn't come up. So we're running through our meds and trying to get the blood pressure up. And then the scenario stopped and we were done. And I passed, thank God. So that's what our simulation lab has been like over this quarter, managing those intraoperative emergencies. If you have questions, comment below. Let me know. I would love to hear what comments or questions you have. If you are a CRNA student or if you're a CRNA, comment below. Let me know what your simulation lab experience was like. I would love to see. It's interesting to compare different programs and see what different experiences have been like for different people. So if you don't mind, comment below. Let me know. I would love to hear it. Thank you so much for watching this video, and I'll see you next time.